our first speaker with his opening remarks. It's been, I've got the most amount of admiration for this guy, having been working with him for several years now, probably. The amount of things that he's had to gone through, and he's been so resilient with it all, and been persistent. It's absolutely inspiring. Doesn't need any more introduction than that. It's Dr. Aseem Malhotra.
So before I start, I just want to, I think, you know, it's really great to be presenting again, 4th year in a row, public health collaboration. It's just growing and growing. And I think this is just the beginning of something really special that is going to revolutionize healthcare. And that we wouldn't have been able to even get this far if it wasn't for Sam. So I think a special round of applause for Sam Felton. Right, so it's back to business. Evidence-based medicine has been hijacked. That's my talk for today. Declaration of interest, I've written a book called The Piopi Diet that many of you know about. I give all personal royalties from sales of the book to charity. Right, so many of you know this. I think it's important to reiterate this, and it will make a lot more sense towards the end of the talk. But really, the reason that we have our healthcare crisis is because we have this epidemic of misinformed doctors and misinformed patients, and the root causes behind that need to be understood and recognized. So we have biased funding of research that's funded because it's likely to be profitable, not beneficial for patients. And in fact, 2/3 of research now in the UK in medical science comes from industry. It's not publicly funded, so that's a problem. Biased reporting in medical journals, biased patient pamphlets, biased reporting in the media, commercial conflicts of interest, defensive medicine, and last but not least, medical curricula that fail to teach doctors how to communicate and in fact comprehend and communicate health statistics. Really important slide that I think explains a lot of why we have this problem in healthcare is that we're not actually able to improve patient outcomes as best as we can because the best available clinical evidence unfortunately, is not very high quality. So some estimates suggest that maybe 10–15% of all published research is actually high quality and beneficial for patients. John Ioannidis, professor of medicine at Stanford, his own predictions, his own predictions suggest, and his own analysis suggests that 85% of published research findings are false. So that's a big problem. And there are many reasons behind that. Some of it's poor quality of research, but a lot of it is because of influence of commercial interests and the bias that comes in with that. And last but not least, patient values and expectations are not taken into consideration. Very often, we think they are, but they're not. And without informed choice, you're not going to make good decisions for patients. You're not going to make good decisions together with patients. And actually, it's actually a relatively simple concept. And if we stick to this, then we can genuinely improve patient outcomes. Of course, we have our individual clinical expertise that informs us over the years as healthcare practitioners or as doctors. But I think one thing we can all acknowledge is that clearly something is very, very wrong if our healthcare system now is or has already collapsed. It's not on the brink of collapse, it is collapsed. We are not able to provide our patients with the best quality care because of the rising burden of chronic disease and too much medicine. And of course, David Sackett, who was the founding father behind that concept, Professor David Sackett, who's now passed away, this is a really important statement that he made, is that science evolves and we need to evolve with the evidence and with the science. And if we don't do that, again, we're selling our patients short. So I'm going to start with an interesting case study, and this is a patient that came to see me most of my work is NHS, but I do some ad hoc private work. So this patient came to see me. His name's Tony Royle. He's given me permission. I published on his case as well to share his details with you. But Tony came to see me a few years ago. His background was he was a 55-year-old, very active international airline pilot with Virgin Atlantic. He had followed a traditional low-fat diet, but not something that was particularly unhealthy in the sense he wasn't eating lots of junk food, but had followed the dietary advice, very active, but still had a BMI that was 28, putting him overweight. More importantly, his waist circumference was increased. He had a routine cholesterol check done, and in September 2014, as part of his annual review as a pilot, and his cholesterol showed it was 6.4. More importantly, his total cholesterol to HDL ratio there is 5.3, which is high. Ideally, it should be less than 4, and he also got an assessment for his cardiovascular risk. At that stage, it came up as 12.86%. So that means there was a roughly 13% chance that he's going to have a heart attack or stroke in the next 10 years based upon this risk calculator. Should he be taking a statin with that risk? You want to put your hands up? Anybody? No? Okay, well, the guidance suggests, certainly in the US and over here, if you've got more than 10% risk, patients should be offered or perhaps coerced into taking a statin with that risk profile. And unfortunately, a few months later, Tony suffered a heart attack. We call this a non-ST elevation myocardial infarction. And luckily, it didn't cause any significant damage to his heart muscle, but obviously it's a major life-changing event. He had a heart attack, he had a stent inserted, he had some what we call bystander disease, so his left anterior descending had a 57% narrowing stenosis. We don't consider it significant or needing further stenting unless it's at least 70% with symptoms. So he had a stent because one of his arteries was completely occluded. He gets put on his usual cocktail of drugs, which I have prescribed to thousands of people in my career, which is 2 blood thinners, high-dose statin, beta blocker. And about over a year later, he starts feeling quite poorly. He's got lack of energy. He reports lack of drive generally. He's got erectile dysfunction. He's got muddled speech, poor mental acuity. Now, what's interesting about Tony, which makes him quite a unique patient, is 2 things. One is Tony could no longer fly anymore as an international airline pilot. He had a heart attack. The rules are he can't fly anymore. So he went back to what he did before this, which was he's a maths and physics teacher, A-level maths and physics teacher. So he's very good with statistics and he's good with maths. So he actually starts looking into some of the drugs. He thinks this could be a side effect of his medications. And he also then teaches himself about the absolute individual benefits of these drugs and realizes that they are quite small. The reality is most patients taking these medications are not going to benefit. We'll call the N and T. I'm going to come on to that in a minute. So he realized all that stuff. And a few months later, because he's still feeling pretty rubbish, he decides to stop his beta blocker. And the one drug which clearly seemed to resonate with him when he looked at the side effects was his high-dose statin. So having felt pretty miserable and suffering these symptoms for a few months, within a few weeks, he feels like a new man. All his symptoms disappear. He notes a marked improvement in health in every respect, he tells me. At the same time, he starts looking at research into low-carbohydrate diets. He's still overweight and he's still active, but he's wondering, why am I overweight? And he starts looking into all of this stuff, and he decides to go low-carb. So around this time, when he stopped his, he's starting to feel better, but he wants to change his diet. So he cuts out the classic foods, as we know, that are high glycemic index carbohydrate foods, high sugary foods, and he increases consumption of non-starchy vegetables, oily fish, eggs, full-fat dairy, and mixed berries. Within 3 months of doing this alone, he hasn't changed his exercise. It's exactly the same. He's lost 3 stones. His waist circumference has gone from 38 inches to 30 inches. His total cholesterol has gone up, but his total cholesterol to HDL ratio has actually improved. It was 5.3 before, but now it's 4.4. But this was the bit so this is the reason he came to see me, having told me all this story. And I'm a cardiologist. And by the way, he's also now, when he's come to see me a few months later, stopped all of his medications. So he's a heart attack patient. He's had a stent. He's not on aspirin, he's not on clopidogrel, he's not on a statin. And he says, listen, I just wanted to ask you, Doc, is it okay for me to do an Ironman? Now, he came to see me saying, I've read about you, you seem a progressive cardiologist, I don't think any other cardiologist would even have this conversation with me. And, and he'd made an informed decision. He knew exactly what he was doing. From my perspective, just to emphasize this, when it comes to coronary artery disease, and you look at the data, there doesn't seem to be, after a certain level of exercise, there is no incremental benefit from a heart disease perspective in preventing heart attacks. So moderate activity, is just as good as doing, endurance athletics. Endurance athletes don't live longer than golfers or cricketers. So I did explain that to him, and I thought, well, we don't know, but it's possible, given your history, that if you really do a lot of intense activity, you may be increasing your risk of a cardiac event slightly, but I couldn't really point to any hard evidence on this. But this was my kind of clinical intuition, and I said, listen, Tony, I think at the very least, maybe you should consider going back on aspirin, and let's try you on a low-dose statin. People get side effects at much higher doses. A lot of people do well on lower doses, and there is some data and literature benefit on statins and secondary prevention, which I'll talk about shortly. Tony went away. We had a conversation or email exchange a few weeks later, and he said, listen, I've made an informed decision. I'm feeling great. I'd rather just stay off all the meds. And that's absolutely fine. And that was the end of that conversation then. We'll come back to Tony later. So let's just take a step back. So let's talk about cholesterol. It's feared. It's a big risk factor for heart disease. This comes from the Framingham study. And what's interesting about Framingham is that when you look at the data, it was only at the very extremes of cholesterol, either being very low, total cholesterol less than 3.8, or very high, more than 10, where there was a very significant, strong association with the development of heart disease or not developing heart disease. But cholesterol, most of it is genetic. You can influence the profile from dietary changes, but most of it is genetic. And you know we have a condition called familial hyperlipidemia, affects about 1 in 250 people, where there is a strong association with heart disease. But if you look at the most people in Framingham, the total cholesterol did not tell you who was going to develop heart disease and who wasn't. And what's interesting is William Castelli, the co-director of Framingham, actually in 1996 published an atherosclerosis, and he said unless LDL, so-called bad cholesterol, was very high, more than 7.8, and we rarely see patients with LDL that high. Most of our patients don't even come close to that. It is basically has no value in isolation in predicting who has heart disease and who doesn't. But what is a better predictor is your total cholesterol to HDL ratio, which is why we use that in risk calculators. And that's crucial and important to understand. Now, where does cholesterol fit into the whole risk factors for heart disease? Or where does LDL fit in? It's actually much further down the line. The most important risk factor is insulin resistance. And this paper published in Diabetes Care in 2011, they concluded insulin resistance is likely the most important single cause of coronary artery disease. A better understanding of its pathogenesis and how it might be prevented or cured could have a profound effect on heart disease. What they're saying is we don't know what causes it and we don't know what to do about it. That's essentially what they're saying. But it is clearly the number, and most people admitted with heart attacks have metabolic syndrome, synonymous with insulin resistance. Now, to muddy the waters a little bit, I was involved in this systematic review published in 2016, and what we found is that if you're over 60, there was no association with LDL cholesterol and heart disease. In other words, and also there was an inverse association with all-cause mortality. In other words, the higher your LDL, if you're over 60, the less likely you are to die. I remember seeing a patient shortly after when this was published, and I wrote about it in the Telegraph newspaper. A lady in her early 60s come to see me in NHS hospital. She was very scared, looked very worried. I said, "What's wrong?" She said, "I'm really worried. My GP has told me my cholesterol is high." I said, "Congratulations, you're probably going to live longer." And I had an informed decision, making conversation with her, and she left the consultation very reassured. Now, 2013, having studied a lot of this evidence, I'd realized that we'd really exaggerated the role of cholesterol, and it neglected us from concentrating on the real culprit driving metabolic syndrome, which was refined carbohydrates and sugar. I wrote this piece in the BMJ. I also decided it was a good opportunity to have a go at statins, which is now going to be, a lot of the rest of my talk is going to be based upon the statin controversy. I wrote this, and obviously BMJ press released it. I was suddenly thrown into the limelight as a cardiology registrar, having to talk about this, having to defend myself against some dietitians from Public Health England, it became a big story. They concentrate mainly on the saturated fat issue, but at the same time, there was some media attention on the fact that I'd said 1 in 5 people taking statins suffered significant side effects, unacceptable side effects. When I say unacceptable, what does that mean? I asked the patient, is this symptom interfering with the quality of your life? If they say yes, it's unacceptable. It's not. And my own observation, seeing patients, looking at observational data in the real world, suggested about 1 in 5 patients had significant side effects. John Abramson from Harvard published a similar paper just looking at statins in the same issue. And what was interesting is he also mentioned that 1 in 5 patients get side effects, and these include something exactly similar to what Tony Royle had experienced as well. In muscle symptoms, increased risk of diabetes, cataracts, sexual dysfunction, exertional fatigue, etc. But the main point of this paper was, do people at low risk of heart disease benefit from statins? And they do not have increased life expectancy. There's about a 1 in 140 chance it may prevent a non-fatal heart attack or stroke if you take it over 5 years. Now, on this, and some of you heard this before, but it's important to reiterate this, is that we have this problem with misleading health statistics, so we have different ways of presenting data. We can use relative risk or absolute risk or numbers needed to treat. So if we communicate relative risks as opposed to the absolute risk, it can lead lay people and doctors, actually, to overestimate the benefit of medical intervention. So if you look at data, for example, looking at type 2 diabetics taking a statin over 4 years, the data from a relative risk perspective says there is a 48% relative risk reduction in it preventing you having a stroke. This is a kind of conversation that's going on all around the world and has been going on for decades when doctors, cardiologists, or primary care physicians have conversations with their patients. It sounds very impressive, doesn't it? 48% relative risk reduction if you take this pill. But actually what that means is it reduces the risk from the data of 28 in 1,000 people on placebo having a stroke to 13 in 1,000, which means there's an absolute risk reduction of 1.3%. In other words, a very simple way of understanding this is, what should be said to the patients is, if you take this pill, based upon this data, albeit industry-sponsored, which again is not part of the conversation either, which I'll come on to, there's a 1 in 77 chance that you take this pill religiously every day for the next 4 years, it will prevent you having a stroke. It's not being helped by the fact that medical journals have been co-opted into this mismatch framing. So, for example, if a treatment A shows it reduces the risk of developing disease from 10 to 7 in 1,000, but increases the harm from 7 to 10 in 1,000, so exactly the same, the journal article will report the benefits in relative risks and the harm in absolute risks. And this actually, from a sample, showed that 1/3 of all papers published in the BMJ, JAMA, and the Lancet between 2004 and 2006 used mismatch framing. When they're presenting the benefits of a drug and relative risk and the harms, it's absolutely, it's ridiculous. I mean, it's actually quite scandalous, to be honest, if you think about it. You know, completely distorts our understanding of what the risks and benefits. And remember that slide at the beginning, patient preferences and values, informed decision-making. It has to be based upon transparent communication of risk. And don't just take my word for it. The world's most respected scientist in health literacy, Gerd Gigerenzer, who I've had the pleasure and opportunity to meet a few years ago at the Max Planck Institute in Berlin, he, in a World Health Organization bulletin, said it's an ethical imperative that we tell patients about absolute risk. So in other words, to not have this conversation with your patient and understand the absolute benefits of an individual drug is unethical. If you've got the data there and you do not use it, it is unethical. It's unwitting. Most doctors are not doing this deliberately, but it is unethical. Now, the controversy over statins started when Professor Sir Rory Collins, who is considered the world-leading researcher on statins in the Clinical Trial Service Unit in Oxford, he contacted the editor of the BMJ, Fiona Godley, in 2013, after both myself and John Abramson had published these articles, and said that we were going to do considerable harm to British medicine, much worse than the MMR scandal, because we had exaggerated the side effects of statins, and it became a front-page story in the Guardian newspaper run by the health editor, Sarah Bosley. And this was actually from a quote from the article. Professor Collins, and by the way, I have to mention, Zoe Harcum had written about this, and I became most aware about these major conflicts of interest. The Clinical Trial Service Unit in Oxford has received well over £200 million in research funding from statin manufacturers, from drugs that manufacture. So I think there may be a bit of a bias there, possibly. It may bias his view. But this is what he said in The Guardian, in quotes, hasn't been changed or corrected. He said there are really only 1 or 2 problematic effects of statins. 1 in 10,000 people, he said, would get significant and a small increased risk in diabetes. Now, back and forth, this controversy went on. I was heavily involved in this, and we moved forward several years to 2016. And Professor Collins, we went this, as many of you know, the papers went for an independent review about whether they should be retracted. There was no call for retraction, 6-0 in our favor. Professor Collins wasn't happy. He then reported the editor of the BMJ, Fiona Godley, for editorial misconduct to the Committee on Publication Ethics for the way that she'd handled the papers because of the delay in looking at all of this stuff. Unfortunately, Fiona Godley obviously came out okay, but many people in the BMJ, who I know well, thought this was an attempt to get her sacked. But luckily that didn't happen. She's been a shining light on the Too Much Medicine campaign, so I'm very glad that she's still the editor there. And then Rory Collins said, okay, we're going to look at the data again and come out with, because of the controversy and side effects, let's just reanalyze it, and what do we think about statin side effects? And they published a review in The Lancet, which became a big news story around the world, that basically statins cause more benefit than harm. The harms are very rare. Muscle symptoms maybe 1%. And they're reversible. The reversibility is certainly true, but whether it's 1%, I think that's very, very dubious in my view. So what I didn't predict is 2 weeks later, the Sunday Times chief reporter, John Gotonis, calls me up, and he says to me, Aseem, I've got something interesting to tell you. We're doing a story. We found something really quite fascinating. And this is excerpts from their Sunday Times article, and basically he wrote about the fact that Professor Collins had led this review from Oxford University in The Lancet, showing that very few people get statin side effects. Collins, who believes millions more Britons could benefit by taking statins, is also co-inventor of a test that indicates susceptibility to muscle pain from them. The test, branded as Statin Smart, was being sold directly to consumers in the United States for $99 on a website that claimed 29% of all statin users experience muscle weakness, cramps, and pain. He also claimed that the marketing material also actually, which is correct, 58% of patients stop statins, and when you ask patients, it's mainly because of muscle pain. Royalties of the patient go to Professor Collins' department. He waived any personal fees. He also said this claim was misleading, but Boston Heart Diagnostics had the license for this device. They actually stood by their claims in this row, and they said that the randomized controlled trials, such as those used in the Lancet study led by Collins, had major limitations because patients with statin intolerance were often excluded. And this is just the Freedom of Information request that Professor Collins' department received £126,000. Oxford University received over £300,000. But of course, at the very least, I think it's a major conflict of interest. It certainly looks very dubious to me what's going on. And of course, it doesn't help when the public or doctors to try and get to the bottom of actually what the true rate of side effects are. So, a broad perspective on the issues around the drug industry and their role in modern medicine. These companies are there to make profit. That's their primary motive. They're not there to sell you the best treatment, and that's what we would like to think that would be the case, but it sadly is not the case. And Peter Wilmshurst in the Centre of Evidence-Based Medicine, Oxford, in a lecture, points out that the real issue, the real scandal, is that there is failure to prevent misconduct by industry, by regulators, and there is a collusion of sorts for financial gain between academic institutions, doctors, medical journals, with industry for financial gain. And that is a big problem. That is part of that system failure. Now, going into more detail, Peter Wilmshurst then submitted evidence to the Science and Technology Committee, and Parliamentary Science and Technology Committee, that were looking into research integrity. And he points out these issues. I think these are really important to try and understand the system failure. So he says, academic institutions bear responsibility for pressure to publish, for career advancement that can result in research misconduct. Of course, if you have prominent publications, it will attract future funding, which institutions demand, and of course, good publicity, which obviously institutions desire. He said there are other pressures for misconduct come from the association of academic institutions with industry, such as when investigators or institutions hold patents or shares, or they receive payments from industry. So there's a financial pressure to publish research that will be profitable for the company and to suppress negative findings. He says some publications are basically just organized criminal activities, which may be at the behest of the sponsors, when prominent academics are paid large sums of money to publish false data by industry, or a sponsor may be one of the victims when payments for conducting research are made to investigators who simply fabricate data. Medical journals also have a conflict because they have financial pressures to publish positive findings. And many of these journals will receive sometimes hundreds of thousands of dollars or pounds from drug companies when they publish their research to get reprints from the journal that they can then distribute amongst their drug reps to doctors. So this is basically part of the marketing material. So there's a huge financial conflict of interest, and including journals like The Lancet, for example, JAMA, and we need to know about this. John Ioannidis says that we have this medical misinformation mess. Part of the reason is lack of knowledge of the system. Doctors, 70% of doctors fail the very basic test in their understanding of evidence-based medicine. So we have to understand there's a lack of knowledge as well that prevents us changing this system. Just moving on, journals are reluctant to admit that they may publish flawed research, and therefore, they will, and also fail to publish failures to replicate. And there is a problem of fear of libel action. So if there are whistleblowers out there and people want to highlight this problem, then those people are in fear of what may happen to them as well. And he says, Peter Wilmshurst said, the best way to address these problems would be by making serious forms of research misconduct criminal offenses with meaningful sanctions, which isn't the case at the moment. One example of how things can go very, very badly wrong, one Dutch researcher was sacked when he was found to manipulate data regarding the use of beta blockers for non-cardiac surgery, and it was estimated as a result of this, and this was also recommended by the European Society of Cardiology, that this resulted in about 800 excess deaths over 10 years in Europe. One bit of fabricating or manipulating data caused 800,000 deaths. This is absolutely scandalous. Why are we not talking about this? Why is this not the main headline news? Why are we not doing something about this to stop it? And the drug companies as well, you know, they have been, most of the top 10 drug companies have been found guilty for committing fraud, mainly in America, for illegal marketing of drugs, hiding data on harms, manipulating research results. And Peter Gosha, who his own estimates, he's a co-founder of the Cochrane Collaboration, that the third most common cause of death after heart disease and cancer now is prescribed medications. He says we need to have some serious sanctions. Nobody got fired in any of these companies. Or the people, no CEOs were fired, nothing, there was no meaningful sanctions brought against this. So of course we've got the problem of the illusion of innovation, and several journal editors have also highlighted their own concerns about published research. Let's just come back to statins now, just to thinking about how statins fit into all of this. So I have published saying that statins have reduced mortality in the population in secondary prevention, but I think I was wrong. And I may need to go back to the journal and get that corrected. Because I just took it as gospel truth. In people with heart disease in the population, statins have reduced mortality. This paper published in BMJ Open showed that actually there is no clear evidence for that. In fact, they looked at uptake of statins in different risk groups in the population, and they found there was no reduction in mortality over 12 years in the population. Now, why may that be? One of the reasons may be that if you take the industry-sponsored trials, which is a selected group of patients, and you look at the increased life expectancy over 5 years, what would you expect? And a lot of you may know the answer to this, but most people don't. The increased life expectancy in secondary prevention is about 4 days. If you take a statin religiously for 5 years and you look at it as a whole group, the increased life expectancy is median is about 4 days. And if you think that most people stop their statins within a year or two, you can understand from a scientific perspective, not because it's fraud. Okay? People have different definitions of fraud. I don't think this is fraud, but you can understand how it can be scientifically explained why there's no reduction in mortality in the population. And of course, there is ignoring a multitude of randomized control trials about cholesterol that show lowering cholesterol, including LDL, has no impact on any cardiovascular events, no impact, on most of those trials, no impact on cardiovascular events. In all the trials, no impact on mortality, and several trials showed harm. So this is being ignored. We've got publication bias, we've got selective reporting of research results and papers that suit certain interests. And of course, the problem is this indirect focus or this misleading reductionist approach on lowering cholesterol has distracted from more important issues. And of course, you know, this picture speaks 1,000 words because many patients have the illusion of protection that they think they can eat what they like if they take a statin. And I've seen many patients like this who are under that false belief. Now, I wrote this paper to try and shift the paradigm about the understanding of heart disease again. This is another paper which got a lot of interest. Recently, I think the editor of BGSM tweeted it reached a lot of interest, more than 1 million views, which is quite a lot for an editorial. I'd written it with Pascal Meyer and Rita Redberg, both cardiologists and editors of medical journals, and really focusing on that what we should be doing is focusing on insulin resistance and chronic inflammation. Through whatever means. I personally, from my own interpretation data, think there is something in the Mediterranean diet. It's not going to be the bread and the pasta, though, that's beneficial. And if you combine that with lifestyle approaches, you know, this is one way of preventing heart disease and may well be a good way of managing heart disease as well. And I wrote this book called The Pioppi Diet, which was mentioned in Parliament. For me, personally, and I was public about this, I said I'd rather the book sell 10,000 copies and it influence health policy than it sell 1 million and that not happen. You know, I did my best to make sure, because I knew there would be a backlash, to get, you know, establishment on board, chair of the Medical Royal Colleges, Sir Richard Thompson, former president of the Royal College of Physicians, chair of the National Obesity Forum time, David Haslam, but that didn't stop, and you know, the mayor of Manchester, former Secretary of State. So I had a lot of very good people to help support this message of the change towards evidence for lifestyle interventions improving people's health. And probably the most prominent man who you'll hear from tomorrow, Tom Watson, who I did not know personally, but contacted me via Twitter and said, by the way, Aseem, I've read your book and it's done all this great stuff for me, and he lost 100 pounds in a year from essentially following a low-carbohydrate diet. And that's all great. You know, there was a documentary in the Netherlands which just followed 3 people for 28 days, one with type 2 diabetes, the other 2 with metabolic syndrome. The man with type 2 diabetes sent his type 2 diabetes into remission in 28 days from following the Pioppi diet, and this documentary which was there, the book came out over there, and then I got sent this. I was quite amused by this, that it was #1 in Holland for about 5 weeks. Then the Dutch Nutrition Council came in and basically said that this was dangerous because we were promoting eating more than 10 eggs a week. Apparently that's dangerous. Coconut oil causes heart attacks, things like that. It was all distortions and nonsense, of course. That's a bit of a challenge to put up with. I'm very happy to debate people in the science, but how do you debate people who are distorting things that you're saying? And then I was invited to various places, including my local hospital, to give a keynote lecture about sugar reduction and my role in sugar reduction and the Piopi diet. But the chief executive of Public Health England, Duncan Selby, called the chief executive of the hospital and essentially was warning her that they shouldn't be giving me a platform to speak. And certainly there should be no recommendation, endorsement, association with the Piopi diet. The Sunday Times exposed this story, which I think was a good thing just to make people aware that this was happening. And Tom Watson, he said it was extraordinary that a government agency responsible for helping people to get healthy has tried to close down a respected cardiologist who just wants to make people well. If they disagree with him, debate with him, but don't silence him. I talked about this briefly last year. I'm just going to raise it again. I've got a few minutes left just to speak. I'm just going to finish just really with where we're going, what we need to do to really sort this problem out in our healthcare system. Simon Chapman, to remind you, is a professor of public health in Sydney in Australia, probably the most prominent person in getting smoking reduction policies introduced in Australia over 38 years. And he talks about various things that needs to be, you need to know as a public health advocate. And one of the things he says is that, sunlight, it can be a very potent antiseptic for malodorous health policy. Okay? And there is no greater sunlight than getting an issue major media attention. And it's interesting, I read this paper having done the kind of things that I've been involved with. I kind of already knew this, but it was very interesting to read his personal journey in this. But one of the things that I always think about and I share with friends and other people involved in this space, many people here, is that you have to grow our rhinoceros hide because, we are really coming up against very powerful vested interests. Unless you're an advocate for an utterly uncontroversial policy, as soon as your work threatens an industry or ideological cabal, you will be attacked, sometimes unrelentingly and viciously. And this, many people may be aware of, this was a front page story in The Guardian, featured on the front page, October 2018. I got an email from Sarah Bosey, the health editor, that was doing an article. Unfortunately, at the time that she sent me the email, my mother was very sick and was dying at the time, so I wasn't able to respond. I don't know whether I would have responded anyway. Her questions were very loaded. But essentially, I was front and center of this piece with other people saying that I was a cholesterol denier. And she was using quotes from people such as Sir Rory Collins, Professor Colin Bagent, who I'm going to talk about in a second, to basically say that we were causing a lot of harm by questioning the role of cholesterol in heart disease. And this became quite a prominent story. Gets worse. Mail on Sunday, a couple of months ago, very prominent story, attacked myself, Zoe Harcombe, who's here, and Malcolm Kendrick, said that essentially we were spreading deadly propaganda about statins. What you've heard today is no different to what I've been writing about and speaking about. It's about transparent communication. I'm not denying there's a role for statins, but let's be honest with patients about their true benefits. So this was written, and they also said, which was very interesting, they used Matt Hancock, the Secretary for Health, as part of the story, made the story a very prominent story, who said that there is no room for people like us, essentially, who's spreading pernicious lies about statins in the NHS. But what was really interesting was only a few days earlier, I had myself met Matt Hancock with David Unwin as well to discuss health policy and tackling obesity. And I messaged Matt Hancock on Twitter directly after this story. I said, Matt, did you know this was linked to me? He said, Aseem, I had no idea. Remember, sunlight is a very potent disinfectant. So the next thing that happened was I wrote 2 consecutive letters over a couple of weeks calling for retraction of Sarah Bosey's article. You can read it online. There's a huge list of errors that she made, distortions essentially about what we were saying about statins and cholesterol. And then a couple of weeks later, I wrote to the editor of the Mail on Sunday calling for retraction. And the I newspaper reported on this, which I was very pleased about, and he confirmed that this obviously had not happened. The Mail on Sunday, Matt Hancock had not known that, and he was implying he would not have said it if he knew this was linked to me. He supports a lot of what I'm doing in public health advocacy role on lifestyle. And the editor-in-chief of the BMJ, couldn't get better than that, editor about the Guardian article, Fiona Godley said, "The debate about who should take statins is clearly still very much alive. The Guardian article seemed to be a blatant attempt to suppress that debate by attempting to discredit those who question the merits of statins in people of low risk of heart disease. The article was misleading and fell well short of the standards for accuracy or impartiality expected of a credible and trusted publication. I believe it needs, at very least, a substantial correction." Now, only a month ago, there was some headlines, which I think went around the world, that if you're over 75, taking statins saves about 8,000 lives a year. Okay? Was it based upon any evidence? This was from Professor Colin Bagent, who happens to be a colleague of Professor Rory Collins at the CTSU. And sadly, his own data didn't even say that. You're not going to live any longer at all. He made it up. Okay? So we're not even now in a situation where we're debating the science. We've got these, these vested interests that I don't know why he made it up or where he got this from, but his own data shows if you're over 75 without vascular disease, there is no mortality benefit from taking a statin. Professor Carl Hennigan at the Centre of Evidence-Based Medicine in Oxford has analysed this himself, and they've pointed out that in that group, by the way, big caveat, industry-sponsored trials, best case scenario, there's a 1 in a 446 chance, if you're elderly, and by the way, this is without talking about side effects, that you can benefit from preventing a non-fatal heart attack or stroke and no mortality benefit. And interestingly, very recently, on the NNT itself, a very interesting paper actually published in the British Journal of General Practice showed that the overwhelming majority of patients at low risk of heart disease, which is 2/3 of the 100 million people taking statins worldwide, would not take a statin if they were told the absolute benefits. And by the way, this is without mentioning side effects. This is just on the small absolute benefit. And many people in secondary prevention would also not take the statin. So Tony Royle actually is not an isolated case. He represents actually what would be a significant viewpoint and decision-making process for those patients, even with heart disease. But we have to be honest about that. Now, where does it all come down to? At the end of the day, this is about shared decision-making. If we want to improve quality of care with patients, then and improve the NHS and reduce costs, informed decision-making and ethical decision-making is one of the best ways to do that, because actually, when fully informed, most of them choose not to undergo an operation. Or sorry, many of them would choose not to undergo an operation or take a medication. And this was picked up, we published this in the Pharmaceutical Journal, myself and Professor Dame Sue Bailey, and it was picked up, okay, fine, maybe a bit of a stretch, in terms of the headline, but making a point that you do not need to take medications essentially to beat heart disease. This is going to be through a lifestyle approach. I think the one thing to say here is, this is a very challenging time, but we really need a revolution in our healthcare. It's not going to happen from evolution. It needs a revolution. I can't do this alone. You can't do this alone. But collectively, we need to fight for our patients, for the National Health Service, to make our population healthier. But it means we also need to make sure that we're not staying silent. We need to shout about this problem. We can't just do this, sitting quietly. And I know many people here are fully behind that. And I'll finish with a quote from one of my inspirations, certainly Mahatma Gandhi. He said, "Silence becomes cowardice when occasion demands speaking out the whole truth and acting accordingly." And if we work together, we will definitely revolutionize healthcare. Thank you very much.